performance, courage, and accountability. Welcome back to Health Policy Off Script. I am Matthew Hart. Policy and reform. Who is responsible? And are they held to account? This podcast will be led by Stephen Lewis and Dale McMurtry, with guest Janet Davidson. Janet is one of Canada's most sought-after voices when discussing health policy and system reform, a leader in so many aspects of our health system. Janet always offers great insight and direction and the willingness to open closed doors. Enjoy.
Thank you, Matt. Today we have a real treat. I think it's fair to say that our guest, Janet Davidson, is a true legend in Canadian healthcare. She originally trained as a nurse, and over a 40-year career that is still underway. She has been, among other things, hospital executive. She's worked in BC, Alberta, Ontario, and Nova Scotia. She's been a deputy minister, and her biggest recent gig was as the one-person boss of the Nova Scotia Health Authority. So if there's anybody who knows how health policy is made, how decisions are discussed, and how compromises and various other accommodations are made, it is Janet. So welcome, Janet. Wonderful to have you here.
Thank you very much, Stephen. I'm looking forward to our chat. Ought to be good.
Yes, indeed. So you and I have especially recently crossed paths quite a bit. And when we talk about really the missing ingredient in Canadian healthcare, why do we generally underperform? That word is accountability. So imagine you've got a minute or less to explain to our listeners, whether they're graduate students or the nurse on the ward or the budding political scientist interested in healthcare. What does it mean to you?
Well, it's a good question. I've been thinking a lot about it. I mean, I think I'm always reminded, John Sherman was my first CEO that I ever worked with. He was the CEO of the University Hospital in Edmonton. He said, accountability is break it up. It's count on ability. So it's counting on something, but understanding that the individual or group that you're holding account for something also has to have the ability to do something about it. And I think there's a big disconnect between the two. The other thing I would say is accountability really is responsibility in measurable ways for specific outcomes. Where are you going? Do you know that? Is it clear? Can you measure it? And then are you being held responsible for getting there? And I think that's really what accountability is. And then the loop, of course, is consequences, which you and I have talked about before. I don't think there's any consequences for not being accountable for something, which I find I bemoan quite regularly because I think it's probably one of the biggest pitfalls of our system, to be honest with you.
Great. And we'll get into that latter part shortly with some examples. But before we do, Dale, you've thought a lot about this. And of course, you have worked a lot at the front end of the system, which is kind of messier, community care, primary care. What's your take on accountability?
Depends on the person. So if you're a politician or an administrator or a clinician or a member of the public, it means something very different. Is it transparency around the way that a decision is made, how we measure performance, and then who's responsible for when things go wrong? So for me, I think it's important to keep in mind that there's multiple lines and levels of accountability throughout the system. But in reality, it's the citizen and the public and the patients who are paramount. And all these various lines of accountability need to work effectively to ensure that our goals, high quality and timely care, are achieved. And the system actually reflects Canadian values.
So I think the points of convergence here that really this is about performance. Whatever you want to do, achieve, that's performance. And let's get to a concrete example about where, particularly in Canada, we have a problem. Canadians wait the longest of any rich OECD country for care. And let's take a subset of that, which is surgical wait times for elective surgery, meaning non-urgent surgery. So if you break your leg, you're going to get your leg set within a few hours most of the time. But if you need a hernia repair or you need a hip or a knee, people wait a long time. This has been a constant and seemingly intractable problem. How does this get framed in the ministry around the cabinet table?
I would say, certainly in my experience around the table, yes, there's concern about wait times. whether it's for ER wait times or surgical wait times or whatever. But it kind of fizzles after that. We'll lay it on, for instance, a performance agreement, which most provinces have with regional authorities or individual organizations. And they'll specify they have to meet within certain periods of time, or they have to do this or they have to do that. But there's no consequences if you don't do that. And there's no assistance in say, well, how do you prioritize this? I've often said accountability in healthcare generally tends to be a one-way street. So the governments may say, okay, well, regional authorities, individual hospitals are responsible for the wait times of patients, citizens that they manage. But there's no reciprocal accountability here to say, okay, well, it's all right for you, the ministry, to say that you've got to do this, but what's your responsibility for telling us our budget on time? It's your responsibility for a variety of things which have a direct impact on your performance. I would say with respect to particularly wait times, we've gone the route of performance metrics till we're up the wall. I mean, there's 2,000 metrics that you look at. Now, usually anybody who looks at one of those sheets will see they're red, yellow, green. And as I've often said, if I see one more red MRI wait time, I'm going to throw up because it hasn't changed.
So let's get to those metrics. So, for example, about 20 years ago, the NHS said, we are going to set a target from the time the family physician says you need to see a specialist.
Yeah.
If you need a procedure, that will be done. Total length of the wait time, something like 90 days. And they got, in the early days of this century, they got sort of close to doing that. We tend to set rather modest and mathematically arcane targets, like we're going to get 90% of people done within 6 months for this procedure, which means, of course, 10% of people are going to wait longer. Wait times, they're long, but they're not terrible. They're usually a few months. But there's this long tail of the wait lists where 3%, 5%, in some cases, 10% of people wait 12 months, 18 months. They fall right in the cracks. Is that taken seriously? And those are the cases that make the newspaper, and they send a signal to the public that this system has totally fallen apart.
Well, I think it's a fear of not being able to meet those targets. I mean, I think it's, in my experience, it's easier just to say you're going to focus on a broad number than to say by doing something, you're not actually going to be treating a certain number of individuals. I think those realities are not presented very well, and they're not understood. First of all, our wait time information a lot of it's useless, as you very well know. I mean, we don't have an integrated system that we can tell, is Mrs. Jones, first of all, does she have a GP? Because she can't get in to see a surgeon if she hasn't seen a GP first.
That's a very good example, because I remember probably 15 years ago, the late, great Cy Frank orchestrated the kind of hip and knee referral system, and it took 10 years to get orthopedic surgeons to sign on to a centrally managed wait time system. I mean, that's a long time to do something that should be, it seems to me, fairly basic. So do you have any levers? What can you do to say, look, ladies and gentlemen, this is not working out for a whole lot of people?
Well, it's difficult, I would say. One power is the power of the funding, is to turn around and say, particularly, you remember years ago, in the last quarter of every fiscal year, governments across the country did hips, eyes, knees, and hearts. And that was the four biggies. And we threw out loads of money because we knew the wait times were problematic, and we gave provinces money in order to deal with this, and they did it. So money's the big one. The other one, I would say, and you raised the point about Cy Frank. I mean, I worked with Cy. Cy was a wonder, an absolute wonder. The same way we had at one time Alan Hudson in Ontario. Alan didn't put up with any BS. He would come in and say, this is not acceptable. This is not acceptable. There are very few physicians who would ever tell Alan Hudson to go to hell. There was also very few physicians, particularly the orthopods in Alberta, who would ever take on Cy Frank. He knew what he was talking about. So I think one of the levers I've used over the years is who are the people out there, particularly the practitioners who are credible, who can actually either wield a hammer or persuade other clinicians to come in line. And I think that's the real challenge. But I've done it a few times. We did it in British Columbia as well on a few things, and it's having the right doctors to be able to lead the charge, I think.
And as another piece of this puzzle, you mentioned the information system. And first of all, we only count wait times from the time the surgery's booked, when it is the wait time from the GP to the specialist, which is even longer. So people are waiting a lot longer in a state of usually pain or discomfort or dysfunction than even the reported data. So let's just talk a little bit about governance. One of the things I would want to know are wait times data. And I would, maybe because I'm nerdy, I would want to do statistical distribution. Like when I see that 50 patients waited more than a year for a hip procedure in our hospital, when thousands only waited 4 months, I would want to know what's going on here.
Well, I mean, being a governor now myself, I would say, yes, it's important that governance has the right information in order to make decisions. But there are days, having spent my time in Nova Scotia as the one-person board there, I sometimes question what is the role of governance in Canada's healthcare system. I mean, I argue, and have argued with Accreditation Canada, the uber governor of healthcare, make no bones about it, is government. It is government. They decide how much money you're getting, when you're going to get it, how you can spend it, on whom, why, and everything else. Yet they're not subject to any of the other accountability measures or reporting that the other parts of the sector are. So I think it's very difficult to try and you can hold, I think now, of going into the budgets for next year in Ontario, and the boards are accountable for the budgets. You say, yeah, but we won't even know our budget until partially through the year. You're telling us that here's the parameters. You shouldn't do this. You shouldn't do this. You can't do this. You should do this. You should do that. Say, well, what for and why? Governance, I think, the word is tossed out as kind of a be all and end all, and I don't think it's doing what it's intended to do.
I wanted to come back to the extent to which we have divergence in wait times in the community. Do we really know why? What are the best performers doing differently? And what did the laggards have to change? And I want to go back to the definition. Are we transparent about our expectations around wait times? Does the public know what's expected of the health system when it comes to wait times? How are we measuring and reporting them? Because I can probably figure out what the ER wait time is, but do I know what specialists' wait times are unless I call around? Then who's responsible for fixing it, and what happens when they don't? Nothing. And if accountability to patients is paramount, then what mechanisms do we have to help them languishing in the system?
But shouldn't it be even simpler? They know when I went on the list. I would think they know that much. They know when the referral is in place. And surely you could have one line of code that says, when a patient approaches 6 months, we call them and find out what's going on. I mean, it's not rocket science. It seems to be quite simple. There's no math. You don't need to be a quantum physicist to do this kind of stuff, but it seems not to be done. Janet, why do you think that is?
Well, in some cases, I think we've bureaucratized it, and I use that term in the worst sense of the word. It's just become a process, as opposed to saying, I mean, I always used to say when I was in Alberta, tell me how this is in the best interest of a patient or in the best interest of a citizen.
And what's their answer? What's their answer?
Well, they don't have an answer in many cases, or they'll come up with some obscure thing that means nothing. And it's very, very difficult because it's not demanded. I mean, you look at, for instance, we talk about the metrics that we use for reporting on one of any million things that we report on, incidents, and we'll compare hospitals on, say, HSMR. And we've got these numbers and say, well, I'm better than them because, quite frankly, I'm killing less patients than they are down the street, so I'm better. Can you tell me how that's better for the patient? But I don't think in any of the discussions that we have, except on a very ethereal level, that patients and citizens are actually first on our agenda. They're not.
So let's segue to another massive accessibility problem, which is primary care. So it's now sort of almost a blasé, tossed off figure. Well, we have 6.5 million Canadians without a regular source of care, and the latest survey was that 25% of adults don't have a regular source of care. One of the principles of the Canada Health Act is accessibility. I mean, without question, this is an extreme violation of a very basic form of accountability. I mean, you can see accessibility to a PET scan in 2 weeks is maybe a stretch, but this is foundational. I mean, we don't have a system if you don't have primary care access. A, what do you think is going on? And B, where is the accountability there? Like, what kind of conversations need to be had with whom to fix this, not 10 years from now, but 18 months from now?
Well, I think a couple of things. Number one, we have to get out of the old paradigm of Tommy Douglas doctors and patients and hospitals. What are the services, the health services and supports that citizens need? That is not necessarily a family physician. I was talking to somebody, a pediatric psychiatrist at Dalhousie, who's done some work with WHO in Africa. And he talks about you should focus on competencies, not credentials. And you see that when we look at, for instance, our response now to family physicians. God knows we got more medical schools now than we've ever had before. One says, well, maybe if we need more medical students, and I won't argue that point too much, then why can't we increase the enrollments in existing medical schools as opposed to putting in place additional medical schools, which in some cases are politically, it's a political decision. I've now got a medical school in my community, but we focus on the wrong things. To just assume that individuals, the only way they're going to get primary care is through a physician, I think is ridiculous. Absolutely ridiculous.
So why does it persist? I mean, not only is that kind of seemingly hardwired, but we've had 50 years of research that nurse practitioners can carry a lot of the load. We can argue whether they can do 70% of what a family doc can do or 90, but it's a lot. And there is fabulous evaluative literature that says they're good. They're as good as primary care physicians are. Why don't governments wholeheartedly embrace that solution, which should be cheaper and faster and more effective?
Well, I think organized medicine, for one thing, is always, never underestimate the power of that group. If they don't like something, to be able to undermine it. I'm not saying that's a deliberate strategy on their part, but that is an extremely powerful group. I mean, for example, look at what pharmacists, if you'd said 10 years ago, pharmacists could prescribe meds, could do a variety of things in the pharmacy that you don't need a family physician to do, we would have said you're out of your mind. But there's courage. And that's what I think is missing a lot, is courage to take on some kind of traditional approaches to things and say we are going to look at and we're going to support alternate modalities, whatever you want to call it, and have all of our ducks in line to ensure that that support is there. You can't cave.
So just to follow on Janet's suggestion of an alternative modality that focuses on accountability, to me, we're not really serious. So here's an example for accountability. What if the government tomorrow mandated that all primary care services within a geographic area were responsible for everyone there and accountable for the health of that population? Like, what would happen? So first, not everybody is going to have a primary care provider, professional, or maybe even a team. But the services that in that area would have to scurry around, work together, share resources, share staff, open doors. So at least in the short term, everyone would have a place to go. It wouldn't be ideal, but would the system collapse? No.
But wasn't that a dream of regionalization? That here's your region, here's your population.
Never did it. They never did it.
And never put primary
care in it. And also, where are the lines of communication and accountability? So there's one line of communication and accountability for physicians, and there's another for the teams. There's another, like, the accountability was not universal, and there was not one budget for the entirety of primary care for a region, let alone just a service.
So both of you have mentioned that in a way you don't think this commitment to universal access to primary care is taken seriously,
No.
which is odd. Do you think that governments ultimately say, yeah, it's a bad number. It doesn't look good on us, but we don't seem to be suffering terrible consequences, and we don't see data that shows that people are dying in the streets. It's not a burning issue for us. Like, what do you think is going on there?
Well, I would say, first of all, I don't think Medicare stands for much of anything anymore. It's a nice thing that was developed, but now those universal principles, they don't apply. We have 13 health systems in this country, and they're quite separate. I mean, I know certainly moving from one province to another, the first thing I do is check out, well, what's this like? What is that like? What is that like? Because it's not going to be the same in every province. You look at provinces like Quebec where they say, okay, you're part of Medicare, but oh, by the way, we won't pay the reciprocal funding arrangement between provinces to pay for your doctors. So any Quebec patient who goes to Ontario, most Ontario doctors are saying no now because the billing is Quebec billing, not Ontario billing, which all the provinces agreed to. And maybe I'm being a bit cynical here, but I think one of the big reasons that provinces hold on to Medicare, one, it's something that people say is important for Canadians, but it is a huge source of money. A huge source of money. And when you get the premiers screaming and yelling about Medicare, it's not about the services, it's about the money, the transfer payments. I mean, I can give an example in Alberta when I was deputy, and we got a whacking load of money, additional money, because of the change in the EPF financing arrangements, for population-based funding. Alberta was growing. We got a whacking load of money. Not all that money went to healthcare. A significant portion of it went to the General Revenue Fund. So,
well, that's been the tradition, right? I mean, that federal transfer, even when there's sort of called it's for this and this and it is basically the money goes to the consolidated fund, and that's kind of it.
I agree, but it's very difficult to turn around and enforce principles of Medicare when a large portion of particularly the governments don't actually, well, first of all, don't know what they are and don't care. And the feds, and they know the feds aren't going to enforce them.
You sort of get into it with the money. There's always money. And as you say, this is a big, giant system. It's $400 billion and about 280 is public. And it's 40% plus or minus of every province's budget. So you'd think that value for money would be a big, big thing, right? Yet we've had a little bit of austerity from time to time. We certainly had it in the mid-90s. And then we invested boatloads of money in the system between about 1997 and 2010. And then, regardless of who's in power in Ottawa, that escalator clause got built in. Harper did 6% a year. And its attitude then was basically, and probably to their credit for being straightforward about it, we're not pretending there's any big accountability here. That's just our tab, and we pay it. So health economists and clinicians who have examined this have estimated as little as 10 maybe, but probably closer to 30% of health spending is dubious or absolutely no value. And yet there doesn't seem to be much of a focus on purely self-interested fiscal grounds for a government to try to address that low value care. What do you think is going on there, Janet?
Well, I think a fair chunk of it is due to lack of courage. You're asking, like you look at, for instance, in a province like Alberta, all these little hospitals all over the place. I mean, even when I was there saying, what these places are long-term care facilities, but we're paying them as hospitals. Their occupancy rate is low. You've got high occupancy rate in the urban areas. Well, yeah, but we can't possibly close a hospital here. Or we can't possibly do this, or we can't possibly do that. There was incidents a couple of years ago in Ontario where they were looking at an emergency department that was actually, the public was complaining that if the emergency department was better funded, they would have more patients going there. Which the reality is, no, actually the patients should all go somewhere else where you have a volume that's high enough that the doctors are going to say, well, I treat more than 5 of these a year. And I'm exaggerating to make a point, but it takes political courage to say, we're not going to do this. we're not going to do that, or we're going to go ahead with this. The Health Service Restructuring Commission would be the big one in Ontario. Look at Kingston, where, I mean, the dude took this commission to the Supreme Court and won. They didn't have to merge with Kingston. Now, subsequently, they did of their own volition. That's more than 20 years later. But it's there isn't a lot of courage for doing anything that's going to upset the apple cart. And a lot of times I would say the apple cart is not necessarily patients who need care. It's more the community.
Some things may indeed take some courage, like if you wanted to redo collective agreement with physicians, but some things just strike me as common sense. We read today that Alberta ERs they're overflowing even beyond historical standards, like 105% occupancy levels in a lot of hospitals, at the very same time as there are up to 35% of bed days or alternate level of care days, which means, for our listeners, there are people in those hospitals who don't need to be in an acute care hospital, but they have no place to go. I mean, this is just cognitive dissonance, right? Supposing you combined a hospital with a post-acute home care budget, so you have every incentive to get people out in a hurry. Why isn't that done?
Well, it is in some cases. I mean, when I was in British Columbia, I mean, at the Vancouver Coastal, we had all the budgets. So we would routinely, as we're coming into the fall, winter particularly, would look at how we flow money to long-term care, continuing care to accommodate challenges that we might be facing in acute care. And the money was allowed to be distributed as we felt was appropriate. I think this is where it comes to the tight, loose, tight. The loose is so tight that, you can't do much with it. And I think of the example in Alberta, where we tried to move money from health into housing to help reduce the number of mental health cases appearing in an emergency department in the winter, who didn't need to be in the emergency department, but they were on the streets, nowhere else to go. Well, who objected? Treasury. Treasury said, that's health money. You can't just move it over to another department. Now, we got around it finally, but the barriers to doing things, including this micromanagement of stuff that should be left, I would say, to the system, the operating system, to figure out what's the best way to do, with certain controls, of course, obviously, but not to micromanage the way they do.
I think you've hit the nail on the head, because this discussion around fiscal accountability is usually about we don't have enough money and there's scarcity, or we're wasting money. But it's ultimately also about resource allocation and how we spend our money and how we do it efficiently. Like, to your point, are we spending money in the long-term care or home care to keep people out of hospital? Are we spending money upstream for prevention? Are we using the most cost-efficient professionals? So the bottom line is that we need to follow the money, and we need to do it efficiently. And we need to make sure that we're spending it in the right places to get the most bang for the buck, and be able to report that back to who we're accountable to, which is the public.
Well, yes. And I've heard, some politicians will say, why should we put money into community care? If I put money into long-term care or acute care, there's a sign that goes up saying this building was built courtesy of the government of so-and-so. You can't do that with community, because it's providing money to provide a whole bunch of community supports in the community, which is much less subject to methods that you use to advertise what you've done here. And I would say that that's a problem.
So we've got a very good, comprehensive, and somewhat depressing diagnosis of our underperformance. But in the seeds of that are, I think, examples of the way forward. So let's conclude this podcast with our optimism.
Well, I'd start with the information. I was part of the Alberta entourage in 1987 when Alberta and Ontario put a whacking load of money with the feds into creating CIHI. And the vision at that time was a single record for every single individual in the country that would follow them everywhere. So here we are 40 years later, and I would say we're almost no further ahead. Well, we spent billions on whether it's Epic or Cerner or Oracle or whatever else you want. But the thing about saying, does this ensure that we have a record that's fully transportable, fully interchangeable? No. And I think having better information, the reason I say that's so important is because when you've got the information, it's meaningful, it's very hard to argue. You'll try, but it's much more difficult to argue when you actually have it in front of you.
If you're going to be accountable for something, you have to know what it is.
Yeah.
What would you be tighter on? Like, what would you specify?
Oh, well, I think when I said accountabilities, what are the specifics that you're expecting? And then say, okay, so what would it look like if I stepped into this tomorrow? And then you develop some very specific measures that you can then hold. It's hard to hold people accountable for, reducing wait times in Emerge. Well, what do you mean by that? I think there's an important thing, Stephen, you and I have talked about it, about being very specific about the measures, and God knows not have 5,000 of them, please.
And how do you make the accountability stickier and more real? Again, with actual, clear, unambiguous targets that, if they're really useful, won't be met. The stretch goals are the ones that get the improvement, not the modest ones we can leap over, in our sleep.
No, well, I mean, in my experience, and that's with Alberta Medical Association, British Columbia, and Nova Scotia to some extent, they have to be transparent. I mean, I'm always a big fan of, don't start with a formal meeting of 50 people around a table and figure you're going to get anywhere. You won't. I would do it on a one-on-one or two-on-one or something like that. You say, look, we have a problem here. Now, how can we work together to solve it? In my experience, I mean, while we might complain about different groups, most people, you and I have talked about this, most people go into healthcare because they honestly want to make a difference in the lives of other people. It's what the system's doing that doesn't allow them to do that. So I always come at it from the possibility that we can arrive at a solution to this.
You can have the targets. You can even have decent metrics, which we don't in measurement. But say we have all that, something has to happen when things are not going according to plan. What is the secret to unlocking the consequences?
It's a good question. It's a question of the century, I think. We have to stand for the consequences that we say we're committed to. And that's, I think, where you get a real challenge, because healthcare ultimately is politics more than any other sector that I know. And the minute you start saying you're going to hold them accountable. I mean, we do things in Ontario, you appoint a supervisor. That really hasn't addressed much of anything except maybe give more money to hospitals that go under supervision, and maybe some minor changes. But I think it's going to require a fairly significant education change with our politicians about what it means to be a leader and how you're going to be accountable. And I don't think that's very easy, unfortunately.
Success happens in microcosms.
Yeah.
And as you said before, it's because of the dedicated, bold leaders who stick their necks out. They innovate, they continuously measure, they reassess, they bring their teams along. And this should be the culture of our health system, but it's not. We're risk averse, and those leaders, sometimes when they stick their necks out, they get their hands slapped. Give the leaders the license. They need to be encouraged and rewarded for excellence and efficient care. And then there are consequences to those who don't. Call them out, show their data, reduce their funding, partner them and have them mentored with people who are actually doing a good job. There are a lot of things we could be doing on this front, and we just don't.
Well, and this gets back to the question that you asked, Stephen, about governance. I think this is actually an area where, if ostensibly boards really have some authority, then it seems to me that they could take a role in saying, no, we're covering your butt on this one because we believe it.
Well, Janet, we could go on for days. This has been a fabulous introduction to a crucial topic. Thank you so much for your candor, for the panoramic view of how accountability does and doesn't work. You've made a great start for us, laid a great foundation, and thank you again for joining us.
Thank you.